Okay, folks, hope you all got a chance to look at the posters during the coffee break, and I think we'll all agree that those were fantastic presentations from the trainees, which I always love seeing good trainees presenting, because it's just lovely to hear them presenting, but as I get older, they are going to be the people looking after me, so it's always very, very good to see quality coming through. We're now coming in our normal format to our second session for NIOAN, and that, as always, is a core topics focused session covering the curriculum and also providing us with good practical pointers for our clinical practice day to day. We have a fantastic selection of speakers today, so I think we're going to be brilliantly entertained and educated, and we're going to be brilliantly led through it by the fabulous Dr Laura Martin from Craigavon, and she's going to take us through session 2. Thank you, Laura.
Yes, good morning, everybody. Thank you for 2 speakers here. We've got a third one coming very shortly. And a fourth one as a surprise after as well. So I'm going to introduce now Claire Butler, who is our first speaker of this session. Claire is a respiratory consultant among anaesthetists and other obstetric keen people. She graduated from Queen's in Belfast. She completed a PhD by thesis in mechanism of steroid resistance in severe asthma. And she also went to Brisbane to do a fellowship there. Now she works in the Belfast Trust, and you have an interest in difficult asthma, is that right? And you continue to undertake research and publish in this area. So we're very, very keen to hear what you have to share with us on respiratory disease in pregnancy.
Okay, so thank you for inviting me to present today. So when I realised I had 20 minutes for this, I could talk for 20 minutes on what one dose of inhaled corticosteroid can do to your pathways. So it's going to be a really quick whistle-stop tour through what I think is probably important for the likes of you guys to know about respiratory disease in pregnancy. Okay, so I'll make a disclaimer now. Any questions on physiology can be directed to Sinead McGurk. She knows far more about this than me. But from my reading and pulling out from when I did think about respiratory physiology, most pregnant ladies are at risk of mucosal edema and will often get kind of a resurgence of rhinitis or increased incidence of nosebleeds in pregnancy. As the fetus grows, obviously the diaphragm elevates, but thankfully muscle strength is preserved. And to try and offset the reduction in functional residual capacity, the chest wall circumference will increase to maintain your TLC. Respiratory drive also increases, so it's very natural to see a primary respiratory alkalosis in pregnancy as a normal finding to protect against fetal acidosis. And thankfully for me as an asthma physician, lung function is preserved, so spirometry remains really kind of a good objective measure for us to see how someone's asthma is being controlled and maintained throughout pregnancy. So differential diagnoses in pregnancy, quite often these are managed on the obstetrics ward, but we will often see them come through ED or as referrals on the medical take. The first diagnosis everyone will think of in a lady is it physiological, but we try not to say it's that until we've kind of excluded the more serious, concerning and I suppose easily treatable conditions. A lot of pregnant ladies become anemic, so obviously having a look at their full blood count to see if that may be contributing to their breathlessness is important. Asthma is very common. I'll speak more about it in the next slide, but if a patient's used to doing peak flow, it's reasonable to ask them to start doing that twice daily and see if it's reduced for their age and height matched predicted, and do they have a response to bronchodilators. Is if they feel better when they take a beta agonist or when they take their inhaled corticosteroids, does it improve, is generally suggestive that asthma may be driving it. We all fear having PE diagnosis in pregnancy, and obviously looking at ABGs, thinking about VQs and CTPAs, and I'll talk a little bit about that again in a later slide. If we haven't found a respiratory cause, we'll often ask just for a cardiology check on someone if we think that there may be pathology driving their breathlessness above and beyond physiological breathlessness, and do ECGs and echoes. Pneumonia is common in the general population. It's also common in the pregnant population. So thinking about chest x-rays, sputum culture, and serology. And a chest x-ray is really a very low risk procedure because they put a lead blanket over the baby. So don't ever delay doing or avoid doing a chest x-ray because someone's pregnant. Pneumothorax obviously will be diagnosed on clinical or chest x-ray, and then hyperventilation and anxiety. And having been a very anxious pregnant lady, I can attest to feeling breathless from that. So asthma is the most common disorder that you'll find in pregnancy, causing breathlessness. We often say that asthma is episodic wheeze, shortness of breath, chest tightness and cough, but quite often our pregnant ladies will just complain of shortness of breath. We look for evidence of an obstructive deficit, so that's a reduced FEV1 or peak flows. Not many people do peak flows anymore. If they say they do them, they're generally lying. But we will often give them a peak flow meter for home and ask them to do peak flows twice a day for a period of a couple of weeks, see if there's diurnal variation. So your peak flow is generally lower in the morning if you've asthma, and by evening you'll get a 20% improvement. If someone has known asthma and they've maybe stopped their inhalers, which is a very common thing in pregnancy, patients will stop everything because they think it may be at risk to the baby. We'll ask them to restart that, do a spirometry before and a couple of weeks after to see if there's been an improvement, and generally 15% improvement is suggestive of reversible airways obstruction, i.e. asthma. So rule of thirds in pregnancy: a third of people will get worse, a third of people will maintain disease control, and a third of people will experience a decline in their asthma control. The peak increase in severity of symptoms is around 6 weeks, but thankfully it's very rare to have an asthma attack in labour, although most patients will express that is their biggest fear. Most pregnancies, thankfully, are unaffected, but there is an increased risk of preeclampsia, preterm birth, low birth weight, IUGR, congenital malformations, and perinatal death. Realising how short I am now, I'm having to move to the side to read these slides. Anybody who comes to me will give an individualised treatment plan. I would generally, at the difficult asthma clinic, see patients who are maintenance oral prednisolone. We have a lot of weird and wonderful biologics we now use for asthma. So the first one was for allergic asthma called omalizumab. We only have about 30 people on it, but quite a few of them are of childbearing age. Because of accidental use in pregnancy, it's now we're now able to continue it during pregnancy if we feel it's necessary for disease control. However, the newer biologics that you may see in a pre-assessment clinic that patients are on are anti-IL-5 agents, which are called mepolizumab and benralizumab. They are not licensed in pregnancy and have to be discontinued. But unfortunately, most people who were on those pre-pregnancy will have been on maintenance steroids, so that requires a restart and really an individualised treatment plan and careful follow-up through the pregnancy. From the skins people and also from ourselves, you may find dupilumab coming through, which is an anti-IL-13 IL-4 receptor antagonist, monoclonal antibody, again not for use in pregnancy. So if someone was on maintenance steroids pre-pregnant or pre-dupilumab, it's likely they'll end up on maintenance steroids again. So if you see, so we'll generally know about those patients because we prescribe all those drugs, so we'll have hopefully tackled that before they come your way. But just reach out to either myself or Liam Heaney if someone slips through the net, or you find that they should have discontinued them. We tell them every time they get a dose, if you get pregnant, don't get pregnant on these, come off them 3 months before you get pregnant, but accidents do happen, unfortunately, but need to be discontinued as soon as someone finds that they're pregnant. And as I say, maternal concern is a big issue in pregnancy. Even our patients who are very well counselled will stop their medications because they fear risk to the fetus. So we very much counsel them that the risks of per asthma control hugely outweigh any risks of medications. Beta agonists are well studied in pregnancy and have an acceptable safety profile, as do inhaled corticosteroids and long-acting beta agonists. Theophylline can pass to the fetus in breast milk. In younger people who are childbearing age, it's actually not common to see theophylline anymore because they're such old drugs and we have newer drugs, but often they maybe started in primary care. I don't think they have a big role anymore, and we would generally try to stop them because there are newer drugs that are much more efficacious for patients. Leukotriene receptor antagonists are generally prescribed for patients with coexistent allergic rhinitis or exercise-induced asthma. If they've been on them pre-pregnancy, they can continue during pregnancy, but we would never start them in pregnancy. And corticosteroids should and are used for asthma exacerbation. And again, although there is a risk of increased risk of cleft palate, and obviously diabetes, we would still say the risk of an asthma event or risk of asthma death far outweighs the risk of using steroids appropriately. Now, if someone's on maintenance steroid, we will try and have them on the lowest dose possible. Generally, you're on maintenance steroid because you have eosinophilic asthma, so we'll try and make sure that the eosinophils are 0.2 or below and keep it at that kind of a dose. But again, we see the patients that are on maintenance steroid every 4 to 6 weeks at asthma clinic. Just reach out to us if you're worried about anybody. And I've never seen it happen, but apparently continuous fetal monitoring is suggested in patients who are admitted with an asthma event. We generally get an obstetric review daily if they're in our ward, probably easier if they're in the obstetric wards with an asthma event, but I think they probably feel a little bit nervous if someone's unwell having them on an obstetrics ward. I had to read about labour and delivery because I know very little about anaesthetic drugs, but regional blockade is preferable to general anaesthetic due to risk of bronchospasm. One of the prostaglandins for induction of labour risks inducing bronchospasm, F2A, and ergometrine is reported to cause bronchospasm. This week we actually had a lady transferred over from the maternity hospital who'd been given labetalol of the history of asthma on inhalers, and not surprisingly developed a exacerbation or asthma requiring a course of steroids and a prolonged hospital stay. So avoid labetalol. With regards to aspirin and non-steroidals, about 1/3 of patients with asthma are sensitive to those. If they've used them previously without issue, we generally say if you need them and the risk of not having them, such as for preeclampsia risk, outweighs the risk that it may worsen, that you could consider them. But really asking, patients will generally have taken one in the past and know whether they've had a reaction to it or not. Asthma exacerbation instead is rare in labour, and if someone's on maintenance prednisolone, they must switch to IV hydrocortisone during labour. And this, in the absence of an acute asthma attack, the indication for C-sections for the usual obstetric indications. But my feeling is that there's a lot of push from patients to get a section if they've asthma. Would that be fair to say, or some? So cystic fibrosis, I used to know a lot about cystic fibrosis when I was a fellow, but I don't know a lot about it now. The kind of phase of cystic fibrosis has changed markedly over the past 10 years with the introduction of CFTR modulators, which have pulmonary effects, but also have improved extrapulmonary effects. They can be continued in pregnancy, although there's obviously not a huge amount of evidence about their safety. The one thing that the CF folk told me to mention to you today is that if a mother is on a CFTR modulator, that means the heel prick test could be falsely normal. So any CF patient who has had a baby should be referred to PEDS for proper genetic and sweat testing of the baby, rather than just relying on the heel prick. It's 1 in 25 carrier frequency here. If you don't know the status of the father, the risk of a child delivering with CF is 2 to 2.5%. Obviously, if the father is heterozygous for a CFTR mutation, that's 50%. The survival for patients with cystic fibrosis is markedly improved and is into the 70s now for a child born now. It has pulmonary effects with regards to increased mucus, risk of bronchiectasis, pulmonary infections, and superadded bugs like Pseudomonas, non-tuberculous mycobacteria, Aspergillus. And then obviously nutritional effects and effects on pancreas and GI tract, and a big risk of DIOS, which is a form of obstruction, especially exacerbated by morphine that patients might be getting after C-section, so something to look out for. There is an increased maternal risk in pregnancy with CF if a patient is pre-existing pulmonary hypertension, if they're hypoxic, cyanotic, or of severe lung disease. And for CF, severe lung disease is an FEV1 of less than 60%. And obviously those who are malnourished will have a more difficult outcome. Patients will undergo in the CF clinic kind of pre-conception counselling, diabetes screening, baseline spirometry and SATs, and try and optimise their pre-pregnancy dietary supplementation, enzymes that make sure they're doing their airway clearance, aggressively manage any bugs that may be there. And I did read about a small series of lung transplant recipients post-pregnancy where there was quite poor outcome because of a risk of rejection at a year or two down the line. So in the antenatal and peripartum kind of workup, patients should be multidisciplinary managed with close involvement with the CF team. I've talked about maintaining nutrition and then avoiding a prolonged second stage due to risk of pneumothorax. Tuberculosis, not hugely common before, but probably going to become increasingly common, especially with immigrant populations increasing in Northern Ireland. There's increased risk of extrapulmonary TB in pregnancy, so that's TB that affects lymph nodes, bone, spleen, eye, and the nervous system. And active untreated TB is associated with worse pregnancy outcomes. Patients are able to take the drugs during pregnancy and able to breastfeed when they're on treatment. And if a mother has a baby with, if a mother has TB in pregnancy, the baby should be vaccinated after birth. I reached out to Cecilia O'Kane, so this is all personal communication, but this is worth more than any textbook. Prof O'Kane is the TB guru and very well received across the UK. So she just wanted us to know that rifampicin and OCP interact as a kind of pre-conception issue. Anti-TB drugs are all safe in pregnancy. Patients should have monthly LFTs. They can be nauseated, and obviously if the mother is vomiting, it can lead to poor levels of TB. It can lead to poor levels of TB drugs in the blood. Apologies for my typo there. Latent TB in pregnancy, she said if it's a healthcare worker, they would generally wait till after the pregnancy to start the treatment, just with the risks of nausea and vomiting. However, if it's a recent contact of active TB or an immunosuppressed patient, then you would go on ahead and start TB in pregnancy. And if TB is diagnosed, then the baby should be reviewed within 1 to 2 days of PEDS. But she said any issues with pregnant people in TB, just email her and she's more than happy to communicate with you. COVID, so obviously COVID has dominated the last 2 years for everybody in one form or another. Unlike swine flu, pregnant ladies are no more likely to contract COVID, however, are at risk of more severe illness, particularly in the third trimester. Just look at my time here. Risk factors are those who are unvaccinated, those of BAME, ethnicity, BMI over 25, age over 35, or if they have any pre-existing conditions, especially diabetes or hypertension, and unfortunately those in a public or healthcare facing occupation. I didn't need to tell Sinead this, she already knows that Delta is more severe than Alpha, and Omicron appears to be less severe but more infectious, and we're not sure what role vaccination has played in that. Certainly the Royal College did a big vaccination drive last summer when we saw how many patients were being admitted with Delta who were pregnant, but there still are some coming in, but it's certainly a much more comfortable position for us in respiratory with pregnancy than it was certainly last July, August. Maternal COVID leads to a double risk of stillbirth and preterm birth, and there was an MBRRACE study, kind of a rapid review, and the mortality rate for COVID in pregnant ladies was about 2.4 per 100,000. So COVID vaccine is strongly recommended in pregnancy, and 98% of those patients admitted with COVID or who have severe disease have not been vaccinated. And 2 doses in a booster leads to an 88% reduction in your chance of being admitted with Omicron. And it's important to note it can be given at any time during pregnancy. You don't have to wait for a particular stage, and we prefer Pfizer or Moderna. So the guidelines for COVID, the one that we've usually used is the NICE guidelines, and I had a little circle around version 23. This has been our most frustrating part of COVID. Every week a new a new edition has come out, generally on a Friday just before the weekend. It's not time to disseminate it to everybody. And as governance patient safety lead, it has made my Fridays fairly miserable. RCOG are up to version 15, so they're a little bit more kind in how many versions of COVID management that they are releasing. But I actually find it really useful. Our guidelines, it's really hard to go through it and find what you're looking for. RCOG have been really nice and actually just set out an initial management, what you do in a clinical deterioration and discharge. So I've actually found them really useful in pregnancy, just this one sheet here on the right. So obviously oxygen and keeping sats above 94, thromboprophylaxis as per the RCOG thromboprophylactic guideline. There is some talk in patients who are on low flow oxygen that they should maybe be given therapeutic due to the risk of progression to PEs, whereas if you're on respiratory support, you've probably already got there, so they're prophylactic. But you would be discussing those cases probably with Gary Benson just for a bit more guidance. Corticosteroids, if they're oxygen dependent, for a total of 10 days or until discharge. And that's obviously oral prednisolone in pregnancy, unless they need dexamethasone for fetal maturity, which is given first for 2 days and then on to prednisolone. And there is a suggestion to check their anti-spike antibodies. When we had Delta and Omicron circulating, Ronapreve could be given for Delta, but there's no activity against Omicron, which is, I think, 99.7% of circulating COVID at the minute. So really there's no NMAB for a community-acquired COVID at the minute. If you develop COVID in hospital, you can get Sotrovimab. But it's not for these community folk at present. That may change next week or the week after. Obviously, if a patient starts to decline, convening your MDT, making sure that obstetrics, anaesthetists, ICU, etc. are all involved. Where is this patient best managed? What is best for them and their baby? And obviously thinking about does delivery need to be considered, proning and early discussion with ECMO centres. And just making sure, it's probably on this slide here. So this is a quick reference summary from Royal College of Obstetricians about acute COVID care. It's not projecting particularly well there, but it's really just a flowchart that you can follow if someone presents with COVID, whether they need to be admitted and can be cared for in the community, which is over. Can't get it over on the left side, and do consider prophylactic prophylaxis, thromboprophylaxis, if you're concerned that this person is less than 28 with a score of over 4, or postpartum with a score of over 2 on the green top guidelines. If they need it admitted to hospital, it's really trying to work out if they're mild disease, moderate disease, or severe disease, and then following the guideline down. And then again, really going over what the last slide said, and thinking about oxygen MDT input, neutral fluid balance, steroids, tocilizumab if they have hypoxia and a CRP of over 75. And neutralising monoclonals at present, there's not really an option, but that could change going forward. PE, I'm probably running over. Will I? Yeah. Do you want me to quickly go through it? Sorry. So significant decrease in maternal death from PE. Prevalence of ultimately diagnosed PE is 2.6%, which is less than the general population query PE, but that's probably because we worry about it more in pregnancy. The risk is greatest in the puerperium period. And so basically the green top guideline is your point of reference, but there is a trust, Belfast Trust protocol, which I've included the link for there. And choice of scan, so CTPA and VQ scan carry equal diagnostic quality. However, VQ is a slight increased risk of a suboptimal scan. Other considerations, you can't get VQ at weekends, so generally it's CTPA. If someone has an abnormal chest X-ray, you generally do a CTPA because it can give you an alternative diagnosis and involving the patient in the decision. And I only learned last week that low molecular weight heparin is of porcine origin, so can't be offered, or should not be offered to Muslim patients. Consider fondaparinux in that situation. I actually use this Oxford University patient information leaflet when I'm discussing VQ and CTPAs with patients, because it just sets it out in a really simple fashion for them to see But basically, there's a very small increase risk in the background risk of childhood, above the background risk of childhood cancer with VQ scan. And C2BA, the main risk is the breast tissue for women, especially in the second and third trimester, which will slightly increase their lifetime risk of breast cancer. Obviously, massive or life-threatening MDT and resuscitation team. And onward management, low molecular weight heparin for the remainder of pregnancy, which is for at least 6 weeks postnatally and at least 3 months total treatment. And low molecular weight should cease during labour or 24 hours prior to planned delivery, and avoiding it for 4 hours after spinal anaesthesia or removal of an epidural catheter. And that's a very quick finish, sorry.
That was really, really interesting. Thank you, Claire. She will join us just at the end of this session, where we'll have all the questions to the panel. So we're just going to move now to Johnny Poots. So Mr. Poots is probably the first time we have a neurosurgeon attending the obstetric anesthetic meeting. So we're very, very shocked to have you. So he's also has maybe an anesthetic connection. I can say that he's maybe linked with one of our anesthetists joining the Southern Trust very soon, or maybe in some time, Catherine Poots. So you graduated from Queen's, is that right? And you did your neurosurgical training in Belfast from 2010. You went to Scotland. And then you came back to Ireland, Beaumont Hospital in Dublin, to do a fellowship in epilepsy surgery. So now you're locum consultant in Belfast Trust since February 19, and we can't wait to hear what you have to tell us about neurosurgical complication in pregnancy. Here you go.
So this isn't me with a moustache. This is actually one of the few surgeons which has possibly made an anaesthetist's life easier rather than harder. I'm not sure if anybody could guess who he is, but his name was Mr. Beer. So according to Wikipedia, he's credited with inventing the spinal anaesthetic. Then he and his assistant infused each other with cocaine, spinal infusions, and then basically celebrated with wine and the cigars, and spent a week in bed afterwards, but it wasn't clear if that was due to the massive CSF loss or too much wine. So I was given a brief of talking about neurosurgical conditions in pregnancy, relevance to neuraxial techniques, and what might require extra discussion. The main thing I was told was just don't go over 20 minutes. Essentially, what I'm mainly going to talk about is the considerations to aid quantification of the risk of planned neuraxial labour analgesia or anaesthesia in patients with pre-existing neurosurgical conditions, a bit less about unexpected new neurosurgical related events during pregnancy requiring anaesthetic intervention, and not really very much at all about method of delivery. So topics I'm going to try and cover are hydrocephalus, VP shunts, endoscopic third ventriculostomy, Chiari malformation, syringomelia, tethered cord, spina bifida, spinal dysrhythmism, idiopathic intracranial hypertension, and then just a little bit of everything else till I run out of time or the microphone's turned off. Basically, my patient is in obstetric pre-assessment clinic and has a shunt. What do I need to consider? First thing to consider is why might they have a shunt? So essentially two main types of hydrocephalus, non-communicating, communicating. So if it's non-communicating, there's a blockage in the pathway. This could be something like a tumour. If it's communicating, essentially the full system is open, but the filter is blocked. Reabsorption of CSF is affected, and this can happen after conditions like subarachnoid hemorrhage. But there are many, many underlying various pathologies why someone may have had a shunt inserted. So these two scans show very different things. They both show big ventricles, but the left shows acute hydrocephalus, and that's an emergency, needs sorted very quickly. The right is an MR which shows evidence of chronic ventriculomegaly, which is long-standing, and I could talk through the MRI, but I'll try and keep to time. Essentially, this is a shunt. The main components are A, the ventricular catheter, B, the reservoir, C and D are valve components, and then E is the distal drainage, the peritoneal catheter, and that will run either to the peritoneum, the pleura, or the atria. And essentially, peritoneal is most common, and really we only use the other two sites if the peritoneum has failed. If you're looking at letters, you may see a mention of fixed or programmable valves. Essentially, it doesn't mean very much. It only has significance if they're going, it's the older ones and they're going for an MRI scan. It's a purely mechanical device. It doesn't need interrogated the way a pacemaker or an electronic device would be needed. What signs or symptoms should cause concern? Essentially, everybody gets headaches from time to time, but increasing persistent headache should cause concern. The rate at which a shunt can malfunction and present is very variable, as it depends. Every patient puts a different amount of CSF through their shunt. One patient might put 5%, another patient might put 95%. So if it's the patient with 95%, they may go unconscious within a few minutes, an hour, whereas if it's 5%, it may take months of a slow presentation. Any GCS less than 15 would cause us concern. Visual disturbance. Loss of upgaze is part of paranoid dorsal midbrain syndrome, and my sister told me definitely don't talk about that. Papilledema, new vomiting, persistent vomiting. The Cushing's response is likely a very late sign of shunt malfunction. If somebody has had a laparotomy or C-section, the peritoneal catheter does have a tendency to migrate towards any inflamed areas or the surgical wound, but the rate of malfunction after laparotomy and clean intra-abdominal surgery is likely very low, and there's only a few case reports of shunt malfunction after C-section. If they do get an ultrasound of their abdomen, it's normal to have a small amount of free fluid in the pelvis, as this is a sign that the shunt is working and there's a bit of CSF there. How does a shunt malfunction? Essentially, it could be the top end, that the ventricular catheter is blocked with choroid. The lower end, the peritoneal catheter can block or break, and also the valve may block or malfunction with debris. What we tell patients is that the rate of malfunction of a shunt, that half of them will have malfunctioned within 2 years. Most of those failures occur within a few weeks, but whenever we consent to patients, we say a shunt, it's a mechanical device, it's a bit like a car, can require servicing, parts need replaced, and unfortunately it's multiple surgeries throughout their life. If you are concerned about shunt malfunction, cranial imaging is important. MRI or CT, depending on the urgency. One doesn't give a lot more information than the other. Essentially, this CT scan shows a blocked shunt on the left. Once it's fixed on the right, the ventricles have gone down. But quite often, the scan is just one small piece of the puzzle, because especially if somebody's been shunted for a long time, they've loss of ventricular compliance, and their ventricles may not change even if their shunt's blocked. Some studies sort of say the sensitivity of a normal appearing CT in a symptomatic patient with a shunt, about half the shunts will be blocked, even with their CT appearing to be at baseline. So the shunt series, especially if somebody has a swelling or a soft sort of new area over their shunt, that the peritoneal catheters, as they become older, can malfunction and break. If it's been in the body for a long time, it can form quite a calcified fibrotic tube around the shunt, and CSF can sometimes flow through this, but it will always eventually fail. If you see somebody with a shunt and a large abdomen that isn't pregnant, basically this isn't a baby. It's a low-grade infection of the shunt, and it's an abdominal pseudocyst, and it usually means the shunt needs to be taken out on a course of antibiotics. In extremis or an emergency, there can be an attempt to tap the reservoir of the cranial end of the shunt. This will only work if the top end is still working. But if it's an extreme situation, it may give the patient time to get down to theatre, and essentially a blue or an orange needle can be inserted into the spongy reservoir on the head. You may also see patients with idiopathic intracranial hypertension. These do tend to be female patients, young with a high BMI. Nowadays, nearly all have VP shunts rather than lumboperitoneal shunts, as the lumboperitoneal shunts tended to give them an acquired Chiari. These patients are safe to lumbar puncture. There's no specific contraindication during axial techniques. If this patient came in with a query about their shunt not working, we would lumbar puncture them to check what their opening pressure was. The majority of the management initially is with neurology, and essentially a shunt is towards the end of management, and its main aim is to preserve visual function. Endoscopic third ventriculostomy. So you may find a patient has had this performed rather than a shunt inserted. And essentially, the purpose of this is that if somebody has non-communicating hydrocephalus due to something like aqueduct stenosis, A camera can be inserted and a little opening being made in the floor of the third ventricle in the liquid's membrane. And essentially that creates a new way for CSF to flow in front of the brainstem. And this is a flow void on the MR, which shows CSF flowing in front of the brainstem. And again, if this person's asymptomatic, it can be assumed that this is likely working and they would be safe to proceed as normal. My patient in obstetric clinic has a Chiari. What do I need to consider? So again, there are actually 7 types of Chiari malformation. Most of this is fairly irrelevant. If you see a patient, it's most likely to be a Chiari type 1 malformation. Type 2 is associated with spina bifida patients. So basically, this is just a diagrammatic representation of Chiari. The red line is at the patient's foramen magnum, and it shows cerebellar tonsillar descent below the foramen magnum. The definition of a Chiari is essentially greater than 5 millimeters below the foramen magnum, unless there's other features, and then they sometimes accept 3 millimeters. But Chiari is quite often over-reported on radiology scans, and again, there can be asymmetric descent of the tonsils. So it is something that, although they're labeled as a Chiari, there can be a lot of variability. That the one on the right is a fairly mild Chiari, and it shows that there still is CSF flow in and around the tonsils and through the foramen magnum, whereas the one on the left shows tonsillar descent down to C2 and a very tight foramen magnum with obstruction to flow. So the epidemiology, they say the population prevalence of type 1 Chiari is probably about 0.25%. They've done some large-scale studies looking at MRI scans, and when they analysed 14,000 scans, they found 3% would be defined as having a Chiari. Again, this isn't the normal population, as they've all had an MRI for some reason. Whenever they looked at the ones that had type Chiari malformation, 23% had a syrinx, but a third of these patients with the type 1 Chiari were considered to be symptomatic. So there's quite a few patients that had Chiaris but were felt to be completely asymptomatic of them. So again, in association with Chiari, you can develop a syrinx and syringomyelia. So the scan on the left shows a definite syrinx with septations within the cord and quite wide dilatation within the cord. The scan on the right may also be reported by radiology as a syrinx, but essentially what this is a normal, slightly widened central canal, and you can determine that sort of from the axial images as well, and that essentially doesn't require anything to be done about it. So syringomyelia, as I said, quite often it can be associated with Chiari, but it can also be due to trauma, tumour, arachnoiditis. Symptoms of Chiari malformation, so the patient could be asymptomatic. Online, if you look at the Chiari Association, there's about 30-40 symptoms that could be attributed to Chiari, but essentially some of the majority is a strain, impulse headache, cough, sneezing, cough, whenever they cough, sneeze, stoop, suboccipital pain, neck pain, radicular pain in a cape-like distribution, and various other symptoms, including swallowing difficulty. Also, on an MRI scan, it may be reported that they have descent of their cerebellar tonsils, but it's quite important to differentiate between a Chiari and cerebellar tonsillar descent due to spontaneous intracranial hypotension, as they both do have low cerebellar tonsils, but the management is very different. The radiologist will be able to see a few signs that the brainstem will sag with intracranial hypotension. The mammapontine distance will be reduced. The corpus callosum will sag, the brainstem will sag, the tonsils will be low, and they should be able to differentiate that on a scan. So my patient has had surgery for the Chiari. What surgery might they have had? If they had big ventricles, the initial treatment is usually with a shunt. If the ventricles are normal size, they may have had a foramen magnum decompression. That could be a bone-only decompression, or it could be also an expansion of the dura and a reduction of the tonsils. They may have had a cord untethering. Syringopleural shunts are now very rarely performed. So what exactly is a foramen magnum decompression? Essentially, in theatre, a 3 by 3 centimeter area of bone is removed from the occiput, and the dura is opened in a Y fashion, and a patch is stitched in, and essentially this creates more space at the back to allow CSF to flow normally through the foramen magnum. And you can see in this patient that the syrinx after treatment has reduced. Essentially in theatre, it's a midline incision from the occiput down to C2. The dura is opened in a Y fashion and a patch is stitched into place. This is the only paper I'm going to talk about because I looked for the evidence of neuraxial techniques in Chiari and there was very little evidence that I could find. And again, it's not the best study either. It's a retrospective analysis that they looked at for academic institutions in the United States for a period of a decade. They found 185 deliveries with 148 patients. The diagnosis of Chiari was only actually present in 80% of the cases pre-delivery. So there were a fifth were only diagnosed after the fact, and it wasn't unclear why they were actually diagnosed. They commented that the pre-delivery neurosurgical consultation happened in 36% of patients, but it also states that 36% of patients had either had a shunt or a decompression. So it's unclear why every single patient that consulted with a neurosurgeon had an operation. But in America, you get paid for doing things. And again, I think their study was retrospective and they were probably analysing codes on their databases rather than sort of reviewing each case individually. Whenever they looked at the deliveries, 43% had vaginal deliveries, 57% had caesarean deliveries. Of the vaginal deliveries, about 80% received neuraxial labour analgesia, and with the caesarean deliveries, it was 2/3 had neuraxial anaesthesia and 1/3 had general anaesthesia. They reported a very low rate of complications, basically posterior puncture headache in 2% of patients. This was slightly higher in the subgroup that did have syringomyelia with 12% of the patients. What this study suggested was that anaesthetic complications occur infrequently in patients with Chiari regardless of the anaesthetic management. And although it was primarily they felt institutional preference that drove decisions, they did suggest an individualised approach was best, but also pointed out that a fifth of the patients, it was only found out afterwards that they actually had a Chiari. And again, it's whether they're true Chiaris or could some of them be the intracranial hypotension and again, post-lumbar puncture. My patient has a tethered cord, lipomeningeal. What should I consider? They've had it untethered. Does that change things? So essentially, this shows a tethered cord on the left and also a lipomeningeal in the picture on the right. Essentially, there may be very limited, it's covered by me, but there may be very limited evidence on the lower back, or there could be a dimple, tuft of hair, or abnormal pigmentation. And essentially, we would be very nervous about putting a needle into this. If we untether a cord, what we basically do is open up the dura in the lumbar region and section the filum terminale. And that removes the tension from the cord, but it doesn't actually change the position of the cord. So the cord is actually still in a low position. So it hasn't moved away. How am I doing for time? 5 minutes? Okay. So again, other things that you may come across, pineal cyst, colloid cysts, they're very different. The scan on the left shows a colloid cyst that's starting to cause obstructive hydrocephalus, and this does require neurosurgical treatment and basically removal of the colloid cyst, whereas on the right shows a pineal cyst. These rarely cause problems, and essentially we're referred a lot of them, and the mainstay of management is a follow-up scan in 1 year, and generally if it's stable, it's discharged from neurosurgical review, whereas we're much more worried about colloid cysts than pineal cysts. So intracranial mass lesions, of the primary intracranial tumours that are seen in pregnancy, gliomas represent the majority, and then followed by meningioma and acoustic neuromas, but still metastatic intracranial lesions are the most common tumour found in pregnancy. Concerns are related to ICP and tumour-related seizures. The decision to proceed with any surgical resection of an intracranial tumour during pregnancy versus after the delivery will also be based on the mother's symptoms and gestational age, and does require a lot of discussion. Essentially, I'm sure as you all know, there's a massive variety with brain tumours, everything from a low-grade tumour which may stay stable on scans for many years to a GBM where the life expectancy even with treatment is about 18 months. Meningiomas, again, these are different patients, so I wouldn't worry. But essentially, the one on the left is tiny and wouldn't be of any consequence, and you could treat them as you would treat any other patient. Whereas the one on the right, obviously, they need something done about it. The factors that we consider whenever we're looking at intracranial mass lesions is it supratentorial versus infratentorial? Generally, we're more concerned about infratentorial because the main concern is if you have an infratentorial lesion, is it going to face the fourth ventricle or the aqueduct and essentially cause blockage of this area and then result in a hydrocephalus? Whereas if you have a mass lesion in the convexity up here, it's likely not going to have much of an impact on the CSF flow. Generally, if a lesion does have perilesional edema around it, it means it's faster growing. And again, vascular high-grade tumours can have weak abnormal blood vessels within them that may hemorrhage. Spinal tumours can also occlude the canal or CSF flow and affect your neuraxial techniques. I'm not going to talk very much about aneurysms and AVMs because it used to be very simple that they just put a clip on it and clipped it, whereas now the vast majority of aneurysms are coiled, and again, the patients may require a stent-assisted coiling, so they could be on various forms of antiplatelets as well. And it's very important that if they have had a stent inserted, that their antiplatelets can't be stopped. A coiled aneurysm, it may say it's coiled, but again, it may not be completely secured, even if it is coiled. A partially treated AVM is a lot more dangerous than an untreated AVM. And again, this just shows a basilar aneurysm before and after it's been coiled, and then an AVM before and after it's been glued. Cavernomas, essentially, lumbar puncturing them wouldn't increase the risk of bleeding. On the MRI scan, cavernomas are reported that they tend to look a little bit like popcorn, and they can be called popcorn lesions. This is somebody who has familial cavernoma syndrome, and they have multiple cavernomas. Whenever they're removed at theatre, they tend to look like little raspberries. The reason to remove one would be either that it's caused a hemorrhage or that the person had drug-resistant epilepsy related to the cavernoma. So essentially key points: high variability between patients, shared decision-making and discussion is key. If in doubt, discuss, write to us. We're nicer than you think. We might not have all the answers, but every little helps. 20 minutes and 6 seconds.
Thank you. You were spot on exactly. You're right. I had the timer. So our third speaker. Yes, we'll take note of that. Our third speaker is Kirsty Maclennan. So Kirsty is not here actually with us, but I'm going to tell you a wee bit about her. She is a consultant anaesthetist, the only one in this panel. She is from Manchester, but she graduated in Birmingham in 1999. So she has a special interest in head, neck, and obstetric anesthesia, obviously. She's also a passionate educator, and she really loves sharing her learning. She's holding many titles to support this. But interestingly for us, she's a council member of the Obstetric Anesthetic Association, where she works with the Education and Guideline Committee. So Kirsty is not present with us today, but she kindly agreed to record a talk, and we will listen to her now, and she's going to talk to us for the complication of neuraxial blocks. And I believe we're going to have her talk now. We get all the questions for the three speakers. Unfortunately, she won't be able to answer any of the questions, but you still ask them, and we could probably pass them on to her.
Your block. I'm very mindful that I'm not able to be in person with you today, so I've put my contact details on my Twitter feed here, and please do feel free to contact me with any queries that you may have. So we're going to start by just looking at the aims of the talk today. So the next 20 minutes, I'm going to talk to you about consideration of causes for neurological injury following delivery, not just regional anaesthesia, but obstetric as well. Some national guidelines for monitoring both during and following regional anaesthesia in obstetrics. A methodical approach to take if you are to encounter a mother who is left with neurological damage following birth. And all this will enable you to have prompt recognition when you're dealing with a spinal cord emergency. So we're going to start by some good news. Always good to start on the good. So the good news is that the instance of major complications from central neuraxial blockade in the obstetric population is actually quite rare. Our patient population are healthier. They have less immunocompromised situations. They have reduced spinal cord abnormalities, and the duration in which the epidural is in for is often shorter. They also tend to be hypercoagulable, particularly towards the end of their pregnancies. So when looking at complications, we tend to look at either NAP3 or the NIOAN data. So NAP3 was from 2009, and we'll have a little look at that first. So what the NAP3, so our national audit project, showed was that most complications leading to harm occurred in the peri-op setting. The incidence of complications in obstetrics is actually extremely low. There are approximately 140,000 labour epidurals per year, and although obstetrics accounted for 45% of the 700,000 cases that were reviewed in NAP3, there were only 7 of the 52 cases that actually went for final review for permanent nerve injury were obstetric. Of those 7, a number of them were lost to follow-up. So if you assume a pessimistic view that these patients who were lost to follow-up did go on to have permanent harm, then the pessimistic view would say that permanent nerve injury can occur 0.62 per 100,000 times following a labour epidural, 1.5 per 100,000 times following a obstetric spinal, and 3.9 in 100,000 following a CSE. But if you look at all of the data together, any central neuraxial blockade in obstetrics, looking at an optimistic view, the risk of permanent harm is 0.3 in 100,000. Now, if you compare that to the data from the NIOAN database, which looked at over 3 million deliveries between 2009 and 2014, there were 28 reported cases of permanent nerve injury. And this gave a rate of 5 per 100,000, which is obviously a lot different to that of the NAP3 data. But the thoughts on that are, as this was a voluntary data submission and perhaps less serious injuries or more minor nerve injuries were included compared to the NAP3 data. Okay, so now we're going to look at causes of neurological injury. And I want to start by talking about obstetric injuries, because actually they account for probably most of the injuries that you'll see in your practice. Some studies say that obstetric nerve injuries can occur in 4% of all cases. The commonest reason is compression, followed by ischemia and transection. Now, of compression, the most common nerve which is injured during birth is the lateral femoral cutaneous. And so typically this will give you purely sensory impairment in the lateral aspect of your thigh, and it can also lead you to feel very heat sensitive in that area, but it has no motor component. The femoral nerve, commonly injured for prolonged lithotomy. The lumbosacral plexus and the common perineal, that's caused by compression between the sacrum and the fetal head. So things like obstetric forceps deliveries, particularly with the common perineal nerve damage, as you'll all know, when patients are in lithotomy for a long period of time, the head of the fibula can cause compression. With the lumbosacral plexus damage, the risk factors for that are if the patient is a primate of short stature with a big baby. Obturator nerve, again, fetal head and forceps in the pelvis are common causes for nerve damage. Moving on to ischemia, the anterior spinal cord infarction is a syndrome that you need to be aware of. In 15% of mothers, their blood supply for the anterior spinal cord will come from your internal iliacs, and during long labours, these can be compressed. If you have compression of those, that can often be compounded by hypotension, be that from a bleed or from an epidural even, and the combination can cause you to have ischemia which can lead to signs of low motor neuron signs. So you have a reduction in or loss of your reflexes, you have decreased your power and sensation in your legs. But one thing that will remain intact is your dorsal column. So although pain and temperature sensation will be reduced, your vibration sensation will still be present. So that's just something for you to be aware of. Okay, then anaesthetically, there are a number of reasons why you can have neurological problems following a regional anaesthetic in obstetrics, and I'm going to look at each one of those individually now. So the first one, direct trauma. Some studies quote instance of approximately 1 in 3,000 for an epidural and approximately 1 in 2,000 for a spinal, because the spinal cord can be affected more in a spinal than an epidural. Now, the key for this is if you have paresthesia on needle insertion, just stop. And certainly don't inject. Contributory factors are anything that can make it more difficult. So obesity, a patient that's moving, but obviously other problems like anatomical problems with your spinal cord stenosis or spinal cord anatomy problems. Now, those studies that quote that instance are reasonably old now, and it may be that with the use of ultrasound, we've actually reduced those risks, which would be good to see. Epidural abscess. Epidural abscesses tend to be an insidious onset. That's how they're described. The mother tends to have made a full recovery from her regional anaesthetic, and then the symptoms come on after that. They can be associated with severe pain and focal signs, obviously temperature and signs of sepsis as well. Spinal epidural hematomas. The risk factors of this are anything that makes the epidural harder, but also anything that increases the risk of coagulopathy. And one of the major things we need to think about is timing of low molecular weight heparin and other drugs. And for that, we've got the nice guide from the association. This tends to have a more acute onset. Pain, radicular pain in nature can lead to weakness, sensory abnormalities in the dermatome distribution, bladder and bowel involvement. But the key for this is that it's time critical. It needs to be evacuated within 8 to 12 hours before permanent nerve damage can ensue. So that is the time critical issue. Meningitis, this is the quoted instance, but that does come from non-obstetric practice. One of the commonest pathogens that is found in the meningitis following a central neuraxial block is Streptococcus viridans, which has been isolated in the throats of the anaesthetists who've been citing them. So wearing a face mask when you put in your regional block. And then adhesive arachniditis. Following case reports of accidental injection of chlorhexidine into central neuraxial blockades, it became apparent that that can cause severe problems with inflammation, reduction in blood flow, and nerve atrophy. So the association very much recommends that we don't use 2% chlorhexidine when we do our central neuraxial blockade, but to use 0.5%. And how you use it is important. So you need to be, if you're using it as a spray, that needs to be before you open your pack. And if you're using it as a cleaning solution, then that should be kept separate from your workstation where you have all of your needles on. Okay, so we've talked through the considerations of causes, and now we're going to move on to the guidelines for monitoring. And for that, we're going to start in the actual labour period. So this lady's in labour, she's got her epidural, and we're going to talk now about what monitoring she should have when in labour with a regional technique. So we've got 2 guidelines that we'll look at. We'll first look at the NICE guidance. So the NICE guidance at the moment is up for review. But currently, if you look at the NICE website, it said that all you need to do when a woman has an epidural in, additional to the cardiovascular monitoring, is to do hourly sensory block only. It doesn't talk about motor block. But in 2020, the joint guidelines came out from the Association of Anaesthetists and the Obstetric Anaesthetic Association. And they gave 4 critical points or 4 recommendations. The first one was that the anaesthetist should be alerted if a mother cannot straight leg raise when she has a labour epidural. Following a spinal or an epidural top-up, the mother should be able to straight leg raise after 4 hours. And the woman should be informed of why straight leg raising is being assessed, and she needs to be party to that. So if she is unable to move her legs at 4 hours, she really does need to be asking for assistance or highlighting that with the midwife who can get hold of the anaesthetist. And labour units need to have a policy to guide the assessment, management and escalation of care, and I'm going to come on to that just a little bit later. So to talk about how we in Manchester have enabled our monitoring in labour, We have an e-learning program for our midwives when caring for an epidural. So we've introduced the concept that they need to be straight leg raise monitoring, and they need to be doing that hourly. So they do that hourly with their sensory block height check. The anaesthetist, we attend multidisciplinary team ward rounds every 4 hours, and at those ward rounds, the anaesthetist will also check that the mothers with epidurals can straight leg raise. And we refer everybody to the OAA safety poster, which I'm just going to zoom in on now, which basically talks about the importance of hourly monitoring in labour and then being able to lift your leg up 4 hours after an epidural top-up or your last spinal dose. And if you can't, you need to alert your anaesthetist. So that's a post that we have up and we make sure is included in the education programme. So we've looked at guidelines for monitoring, but now what I want to talk you through is the approach that we take in Manchester for when a patient or mother has a neurological deficit following regional anaesthetic. And I'm going to show you the booklet that we use, which is down here. Oh, yes, the first thing I'm going to do is talk about the regional anaesthetic alert bracelet. So I'm not sure if any of you have seen this in Anaesthesia News by Rachel Mathers and her group. So when the guidelines came out, in order to be able to reach the target of making sure that the ladies can raise their legs after 4 hours, they introduced a bracelet, which they call the Regional Anaesthetic Alert Bracelet. And Rachel describes this very nicely in her article in Anaesthesia News. So the bracelet is put on at the WHO sign-out. The time is recorded as to when the woman should be able to straight leg raise. And if the woman can straight leg raise at that time, she can remove her own bracelet. If she can't straight leg raise at that time, then she needs to alert her midwife to get an anaesthetic review. The feedback from this was really positive. Patients say that they felt safer, able to speak up, that they even set a timer for when the bracelet should come up, and that they felt it was the first milestone in getting home. So we thought that was a great idea in Manchester. The only problem that we have is we have a really diverse set of patients who have very different languages. And so putting a bracelet on would be difficult for those who are unable to read that language, or literacy. Some people struggle to read, and then compliance would even take it off. So with us, we think for our patient population, that probably wouldn't work, but we like the idea, so we wanted to modify it. So what we have coming through our system at the moment, it's being printed just currently, is we are going to go with a regional anaesthetic alert bracelet. We're going to stick with the colour yellow. White is our name band, red is our name band if they have an allergy, and green means that the mother's got a vaginal pack. So yellow fits well in our colour scheme, and we're going to have 3 things on it. The first thing on it will be a straight leg raise time. So it'll just say straight leg raise at and 4 hours post the epidural top-up or the spinal. It'll then have a time, which is 6 hours after regional anaesthetic for the catheter to come out. And then it'll have a QR code on it. And I've been specific about the fact it's dynamic because it needs to be able to change in time as we add more languages. And the QR code, the women will be able to scan themselves, and it will take them to a patient information leaflet, which we are going to translate into all of our major languages. So that is work that we've got ongoing at the moment. And that is the poster for the patient information, which has been adapted by one of our medical students from Nico's original poster, which is on the OAA website. Okay, so that's how we're going to inform our women, and then to inform our staff, we've got a really clear guideline in the way of a pathway. So we use pathways a lot. We've already got a pathway that we use for our post-dural puncture headaches, which works really well for our anaesthetic team. So we've devised another pathway, but this is purely for neurological deficit following regional anaesthesia. And I'm just going to talk you through the pages of it now so that you know what it shows. So the first page, it has the contact details, and it has the details of the neuraxial procedure that's been performed. So it talks about the size of the needle, the level that's been instrumented, the number of attempts, any immediate complications, including neuralgia or blood in the catheter, the time of the last dose, if it's an epidural top-up, the time the catheter is moved, and specifics about the timing of the low molecular weight heparin. The next page is a history of presenting complaint and any past medical history, including pre-existing neurology. Then just a signpost to risk factors, including sepsis, coagulation, if the patient's immunocompromised or diabetic. And then is there anything relevant in the obstetric history? If the patient's had a normal vaginal delivery, if they've had an instrumental, has it been a cesarean, has it have a prolonged second stage, or has the mother been in prolonged lithotomy for either second or third stage? Then it goes on to the examination, tone, reflexes, sensation. And in the sensation, the anaesthetist who's reviewing the lady will just have to colour in or shade the area that is affected. And then the power assessment. And we've been really specific about this because we think sometimes people are not entirely sure what movement links to what nerve supply. So we've been really specific about that and really specific about how we want them to test it so that we know they're testing everything with a really clear way of doing it. Because that means that if we test them the next day, we're using exactly the same algorithm to do that. And then some red flag signs that we really want people to be aware of: persisting progressive neurology, nerve root pain, symptoms including bladder and bowel symptoms, saddle anaesthesia, bilateral signs are a bad sign if there's severe back pain, and any signs of symptoms of meningism. Now, following the assessment, they'll come to this page, which will allow them to work out where they think the neurological problem lies. So you have your sensory findings, your motor findings, what nerve root it may map to, and then what treatment algorithm you now need to go down, if that's referral to the physio, or if it's referral to neurology as an outpatient, or is it more urgent? Do you need to refer to neurology now and get an MRI scan? So that's the algorithm. And then in order to get an MRI scan, we take you to this page. So this is if you're suspecting an epidural lesion. Bit of information here about it if you think it might be an epidural abscess, other things you need to do. If you're considering an epidural hematoma, anything with red flags brings you to this page. It has to be discussed with the consultant anaesthetist, and then at that point you decide how to get your imaging, and that will depend on if it's in hours or out of hours. And we've stuck with MRI imaging rather than CT scanning, so this is all about how to access MRI scanning. And to make this booklet, we've involved the neurosurgeons, neurologists, and really importantly the MRI scanning team, because without them we can't get our images at the end. So I hope you found that run through helpful. And if there's anything I can do, any information I can share with you, please don't hesitate to ask. And thank you very much for listening to the presentation today.
This was really, really good, wasn't it? Now, if you have any question for her, either you put on a chat and we can record them, and there are couples that we're going to send to her. So just please do that and we can gather them. So now we have Dr. Julie Anderson. Is she? Oh, wait, yes, sorry. No, you can't. So Julie, thank you for coming. You're going to go beside me. So Julie is a consultant perinatal psychiatrist in Northern Ireland. She works in Northern Trust. You have a passion for a lot of things, but for perinatal mental health, and we're very pleased to have you here. And you have been involved for many years and had a key role in the development of the new perinatal community mental health team in the Northern Trust. Is that right? You're also a very keen educator, as we had in our previous speakers. And we're really looking forward to hear your talk as you share your passion for perinatal mental health. Thank you.
Thank you. It's not quite sure, no, I don't like this. We're just going to pretend that's not happening beside me. So hopefully some slides will appear. Do I need to do something? There we go. Do I need to do this to move them on? Just click towards us, yeah. Towards you, okay. So yes, thanks very much for having me along. I am not quite sure what to add to what's already just been said. My head has been completely immersed in perinatal this week, even though I actually cheated on my slide. Because I'm not officially a consultant perinatal psychiatrist until the start of May, but I'm just a wee bit overly excited about it actually happening. So I've started just to put it on my slides now. I think that's okay. Maybe that's a probity issue, not quite sure. But yes, I've spent all week doing lots of perinatal training with medical students and with MDT stuff at CSEC, and then today as well. So it's all very lovely. Talking about stuff I like to talk about. So this is what, I wasn't kind of quite sure what you guys need to know or want to know, to be honest. So we'll just talk about what I want to talk about. And then you can feel free to obviously ask any questions, but this is kind of an overview of what I'm going to try and kind of rattle through over the next 20 minutes or so. So a little bit about what perinatal psychiatry is. Again, the danger I think is sometimes that I find when you're really immersed in something, you think somebody else is as immersed and understands all the stuff that you think are basic stuff when you're immersed in it. And that's not obviously the case. But a little bit about what perinatal psychiatry is about. Touching on MBRRACE, which I think is why I was asked to talk, and literally one slide just for indulgence, just to let you kind of have an update on the kind of new perinatal teams across Northern Ireland, and then a bit of resources. So hopefully that sounds okay. So perinatal psychiatry, every time I kind of say anything about it, I always reminisce back to when I was first and second year school person at Belfast High School doing a bit of Latin, and I hated it. And as with many things, I think as you get considerably older in your life, and now approaching well into my 40s, I kind of wish I paid more attention at that stage of my life, because actually it would have been quite useful. But we're not going to do too much about Latin other than to kind of say, so perinatal obviously comes from Latin, so it just means around birth. And really perinatal psychiatry is about the prevention, which is actually the really exciting bit, if we can manage to do that. Early identification and treatment of mental illness during pregnancy and the first year postnatal. If I was talking to you in the mainland UK, I would be saying now up to the second year postnatal. We kind of think we have to get things right for a little while, so we're sticking with our just up to 1 year locally. I kind of quite like this quote. Sorry, it's a little bit blurry, whatever way I've copied and pasted it. I think I'm possibly getting a little bit more reflective as I get older, which is probably a good thing, I think. But this quote, I think, kind of just sums up a lot of things and actually gets me a little bit every time I read it. Probably thinking personally of the fun I had 14 and 17 years ago having babies. And actually I was feeling slightly uncomfortable sitting down there. Again, maybe not quite saying flashbacks, that's pushing it a little bit far, but thinking about getting epidurals myself, again, 17 and 14 years ago. But as it stands, motherhood is a sort of wilderness through which each woman hacks her way. Part martyr, part pioneer, a turn of events from which some women derive feelings of heroism, whilst others experience a sense of exile from the world they once knew. And I think kind of just broadly, it's helpful just to kind of hold that in mind, or keep that in mind, that actually sometimes the kind of perception of what motherhood and pregnancy and childbirth is going to be like isn't quite sometimes the way it kind of actually is in reality. And that's probably the case for most things in life, I guess. Going the wrong way. Okay. Again, a slide that or this kind of concept, I suppose, I talk a lot about to anybody who will stand still long enough to listen to me, particularly with kind of medical students and whatever else. But again, I think it's something just that's important, even though we sort of know it, just to kind of continually come back to and ram home. And it's really just about remembering that physical health and mental health very clearly interact with each other. We can't nicely separate out. Might be nice sometimes, but they all influence each other. And that's particularly the case in this kind of perinatal period, where a mum's mental health and physical health really interact with each other and have a big impact on the baby as well. So the mental health of the mum in the perinatal period very clearly influences the baby's well-being, the obstetric outcome, and actually then as well the child's development going forward. And the evidence of that's been increasingly clear of actually just the potential, we need to be careful how we talk about this, but the potential detrimental impact on the unborn baby if the mum is really unwell with her mental health during pregnancy, even as that person grows up. A couple of wee bullet points of actually kind of why I really care about all this kind of perinatal mental health stuff. So not very cheery over in the top corner, but the reality is, unfortunately, that this kind of perinatal period, particularly the early postnatal period, is actually the time when for any female, she's at the highest risk at any point in her life of developing a new mental illness or having a relapse of a pre-existing one, even if she's actually been well for a long time. So I suppose knowing that kind of leads us to kind of a really good opportunity to actually intervene early before things have started to go wrong, and to be proactive rather than reactive. Again, not terribly cheerful. But suicide still remains the leading cause of maternal death, and that's specifically if we're looking at kind of late maternal death, so actually kind of 6 weeks up to 1 year postnatal. Lots of complicated stuff which around medications whenever someone is pregnant or breastfeeding. And I might be less passionate, enthusiastic once I'm actually having to do this job and help people make really complicated decisions. But anyway, we'll not worry about that today. Okay, and for those, I suppose, who are more money motivated, like many things, if we actually invest a little bit and get things right at this point, we actually save lots of money kind of down the line to kind of health service and actually the wider economy. As with anything, if we can prevent problems or intervene early. So roughly about 1/5 of mums will develop some sort of mental health problem in the perinatal period. So it's quite high, kind of roughly 1 in 5, very high, 1 in 5. Now that's obviously a spectrum. So for some of those mums, it will be simply still a big deal if it's you as the individual, but for some of those mums, it will be reasonably mild. So reasonably mild anxiety, reasonably mild depression. They can still manage, still function day-to-day life, but it's still kind of there impacting them, but it's not sort of stopping functioning. It's not maybe at the level where they need to be coming to mental health services or specialist mental health services. But that's obviously a range of severity. So for some of that 1 in 5 group of mums, it will be much more severe illness that can have a massive impact on functioning, a massive impact on her ability to be a mum, and ultimately at the severe end of the spectrum, leading to death through suicide or even infanticide. So I suppose it's really important for all of us in healthcare, I guess, which is why I'm telling you about it, to at least sort of try and think about actually who are the mums who are at high risk of becoming really unwell, because again, that's the ones I suppose we want to kind of focus on. So any mum who has a past or past history or present severe mental illness, so particularly mums with bipolar I should have first, because they're actually the ones we get really worried about. So mum who's a diagnosis of bipolar, schizophrenia, significant depression, or psychosis in a previous perinatal period, postnatal period. Any mums who have kind of needed input from mental health services or specialist mental health services. And again, I suppose the key thing is, even if that's been 10 years ago and she's been really well in between, actually her risk of becoming ill with regards to her mental health in this perinatal period is actually still significantly higher than somebody else if she has that history. And I suppose this is the kind of stuff we talk to the midwives an awful lot about as well when they're doing the kind of booking and trying to get the history. And I know they have thousands of questions to go through at booking, but the kind of mental health stuff is obviously really important. And as well then actually, if that individual mum has no history of mental illness at all, if she has a family history of perinatal mental illness, so an aunt, a mum, a granny who has had mental illness when they have had children, then that puts that individual at increased risk. Or indeed if there's a family history again of bipolar, and there's something about bipolar and babies that doesn't mix very well, there's a kind of that significant increased risk. Quite like this little slide, again the details don't particularly matter. So this was a kind of pretty seminal study in the world of perinatal psychiatry done back in the 80s and then repeated kind of 30 years later in Scotland. And all it is just a visual, it's important, it's kind of just really sort of showing that. So it's the kind of pregnancy and then postnatal period, and it's just kind of showing the rate of admission, or the number of admissions for mental health, so the numbers of psychiatric admissions. And hopefully even if you're really flagging and waiting for your lunch desperately, you can still see there's a pretty clear kind of spike in the middle, and just showing that real increased risk of admissions for someone's mental health in that very, very early postnatal period. And again, all this slide, it's a pretty seminal slide. I quite like it, but I may be a bit odd. But really all this is showing is kind of childbirth down in the far corner, the kind of days since childbirth along the bottom, and again, the kind of risk or percentage of women who have a relapse of mental illness. And the key thing to remember, all the different colours don't really matter as such, but the key thing to note is just the red line along the top is women who have a diagnosis of bipolar, and they kind of really sort of separate out with quite significant sort of risk of becoming unwell, again in the very early postnatal period, and then kind of floating along. Schizophrenia is the ladies in the blue line, and then lots of other mental health problems kind of bubble at the bottom. So confidential inquiries, is this stuff, again, I don't really know your world very much, even though I know a few faces here, but as kind of MBRRACE and confidential inquiry stuff you're pretty familiar with. Yeah, obviously a kind of different aspect of it than me. Okay. So you kind of know about them, obviously recording deaths for many, many years and looking into them for sort of 50, 70 years. And specifically, they started looking at deaths from mental health causes over the last 20, 25 years as such, in the same detail, and kind of looking at cases and learning from them. So just the kind of way they break it out. I'm interested in slightly different years than you guys are. So obviously every 3 years they focus on particular aspects. So 2020 was the last year where you guys were focused on from an anaesthetic point of view, and then 2021 was the last time there was a kind of specific psychiatric or mental health focus. Anyway, that's how it all works. I'll not tell you about that either. So this is the kind of infographic that, again, you're probably all familiar with. I'm not going to say very much about at all because it's a little bit more your world than mine. But this is from the 2020 inquiry, and this was the kind of little infographic as such with regards to the kind of key learning points. Yous are doing pretty well. Maybe I should change my career. So death relating to anaesthesia, you already know, I'm sure, and are pleased to know it's a pretty small percentage, it's a pretty small amount. Mental health stuff, psychiatric stuff kind of sits in the middle, kind of there. And it's divided into direct and indirect death. So it's now started to be recorded and captured that suicide is captured as a direct cause to do with the perinatal period as such, and then indirect causes to do with psychiatric stuff is mainly to do with substance use. So mum who has died directly related to substance use in the perinatal period. The cardiac guys are doing a bit worse than the rest of us. So, and I'm not really going to talk about these. You guys probably know about that. I'll just kind of flag it up there. So again, that was just the key learning points from the 2020 report, specifically looking at anaesthetic practice and the key points of kind of learning from that. And then this was the latest one, the November 2021 report. And again, one of the areas of focus on it was more kind of mental health and psychiatric. So that kind of tends to be the one I kind of pour over. And I suppose have started over the last couple of years sort of helping reviewing some of these cases. So obviously there's anaesthetists and psychiatrists and midwives, and lots of people kind of look at different cases in a lot of detail. And they're kind of tough reading because it obviously gets down to the individual mum and the individual circumstances in the story. And you're kind of starting to read through case notes, knowing there's going to be a pretty grim end before you kind of get very far. But really, really useful learning. Again, the kind of graph from this roughly looks similar. There's no kind of big changes as such with regards to the underlying cause of maternal death. Again, kind of this was the kind of number. So 120 mums died in that 3-year period in the 2021 report from reasons relating to mental health. So roughly half directly as a direct cause through suicide, and roughly half related to substance use. And I suppose kind of actually overall, one of the big things about the latest inquiry is, slightly depressingly, the kind of overall rates from all things not just to do with mental health, you know, overall haven't actually reduced over the last decade or so. You'll be pleased to know I'm not going to go through each of these, okay? But again, from a mental health psychiatric point of view, these are the kind of key learning points from the most recent inquiry. So I'll touch on just the first couple, and that's all I'm going to sort of focus on. But I suppose for myself and kind of psychiatry and mental health, I don't know if it's the same in obstetrics, it tends to be the same things that we kind of have to keep trying to focus on and keep trying to talk about and keep trying to do a little bit better, rather than lots of brand new things. I'll say one other thing about this slide before I kind of just look at the first couple. Loss was a new theme, I guess, that came out, and how a loss really can put a mum at increased risk around sort of self-harm and suicide. And it was quite striking, actually. There was quite a significant amount of the cases over the previous 3 years. So losses relating to a mum who had had a miscarriage or a stillbirth, or a mum who had had a termination, or a mum who had had a baby removed for all sorts of different reasons, you know, sort of through social services. And that was something that kind of really came through, that seemed to be kind of a new thing. And it's pretty obvious, isn't it? You know, if you've suffered something pretty grim, pretty traumatic like that, it is going to increase risks. But it was something that kind of really came through quite strongly. And some of those were losses that had happened very, very, you know, recently. So, you know, one of the cases was a very young 19-year-old who had had a termination and ended her life through suicide within a week or so, kind of really, really soon after that. Some were maybe much more historic cases. So we'll touch on a couple of these. Communication. oh, if only we all could do it a little bit better, wouldn't life be wonderful in all aspects, not just in work? But I suppose one of the main things around communication, and again, in my world, in mental health, services are really complicated. You know, I struggle sometimes to understand how the mental health system works, even within the Northern Trust where I work. You know, so how are other people meant to understand how to navigate it? And I suppose that's one of the really sort of big things about the new perinatal teams. Really, their job will be nothing terribly fancy other than to make sure communication works really well and really tightly about each individual mum. And really, I suppose the big things around communication, this most recent one, were that making sure that everybody who was involved with a mum's care in this kind of perinatal period was clearly aware of any past history she had around her mental health or previous mental health treatment. So cases where mums died who, you know, there wasn't information passed through to the midwife from the GP, for example, and then, you know, about a significant history of mental illness. And then even though the mum was asked by the midwife at the booking visit, she sort of the mum didn't bring anything up. The midwife didn't probe because she has 1,000 questions or whatever it is she has to go through. And then kind of tragically, when the case was looked back, actually there was a very significant history of mental illness for that individual mum that potentially, if that had been known about, there could have been a different plan put in place. Again, I've mentioned already just this sort of theme of kind of loss or traumatic events, and that really putting mums' risks up with regards to sort of self-harm and suicide. You guys talk about red flags in a different world than I talk about red flags. So we have red flags as well. And I suppose, again, just things that are meant to make us sit up, pay attention, do something about right now, not to ignore or not to do something about next week. And these red flags in the most recent report are exactly the same ones as there's been in previous MBRRACE reports as well. And really, it's just about kind of any mums, sort of pregnant or postnatal, who are expressing any thoughts around violent self-harm or have actually acted in any way to significantly harm themselves. Something needs to happen that day about this mum with regards to psychiatric assessment. Any mum who's expressing any new or persistent expressions of being incompetent as a mum, again, need to be taken really seriously. And I suppose I always smile, is maybe the wrong thing to say or do, but you know, anyone who has been a mum, I think there's probably something abnormal if you don't at some point think, I'm doing a crap job, somebody else could do a better job, I'm really rubbish at this. So it's normal to sort of think you're a bit incompetent, a bit rubbish. But these were kind of mums in the cases who, you know, really to even delusional intensity kind of really believed that they were incompetent, even started to make plans for other people to look after their babies that were very much wanted. And that obviously needs to be taken very seriously. And any mums who then were estranged from the infant, so usually around social services, decisions being made to remove the baby and then the mum ending her life. So kind of self-harm in pregnancy, early postpartum period is unusual and needs to be taken sort of seriously, needs prompt referral and psychiatric assessment, ideally to specialist perinatal team, which you'll all have to refer to soon, all across Northern Ireland. And I suppose one of the dangers in mental health services is self-harm isn't unusual for us. We see people all the time who have thoughts about self-harm, who do self-harm, and that's the danger then, that it's kind of seen as just something that happens instead of looking at it differently in the perinatal context. So briefly, kind of a case, which I think always kind of brings it to reality, I guess, or into focus. So a mum who was in her 30s who died violently 2 months after the birth of her first baby. So this is a mum who had no previous psychiatric history, developed what appeared to be a rapid onset anxiety and depressive symptoms 3 weeks after giving birth. She became more depressed and more preoccupied about her baby's health and her belief that she was just inadequate as a mother. She self-harmed by cutting her arm and was described as quite guarded in most assessments. So with different assessments with different professionals, wasn't really saying very much, probably saying that things were fine when clearly things were not fine. She was, in fairness, this was in the mainland UK, so we still don't have a mother and baby unit here in Northern Ireland. If anybody can sort out that problem for me, that would be wonderful. I would really appreciate it. But currently, if a mum is admitted for her mental health, then she is admitted to a general psychiatry ward where her baby can't come with her. But this is the mainland UK where they have mother and baby units. And in fairness, that admission was offered to a mother and baby unit to this mum, but she declined it, and she was managed by a home treatment team at home. But then shortly after that ended her life. And the kind of learning points are pretty obvious from that. Clear review of any previous history. Now this mum didn't have any previous psychiatric history, but recognising that escalating pattern of severity, sort of idea of a red flag that I've mentioned already. And then amber flags. So we don't get quite so excited, but still need to do something. And this is more the kind of stuff I touched on already. So any mum that there's a past history of any type of psychotic disorder at all, and that could be a mum who has a history of a psychotic disorder that is not necessarily schizophrenia or a bipolar illness, but it could be even a drug-induced psychosis that maybe we in mental health services don't take as seriously if it's settled. But any history of psychiatric disorder needs to be taken seriously, and that mum needs to have much closer monitoring, particularly in the early postnatal period. Any woman who has a family history of bipolar or postpartum psychosis, as mentioned already, or if the mum themselves has a mood disorder or a history of changes significant in her mood in a previous postnatal period, needs to be taken very, very seriously and urgent action. So again, a case, just put into context very briefly from MBRRACE. So a mum in her late 30s died violently in the 3rd trimester. She had a prior history, again, this is mainland UK, she had a prior history to a mother and baby unit after her first child was born and had a diagnosis of bipolar. So really unwell with her mental health after baby number 1. Also required inpatient care after baby number 2 for her mental health. So really significant history of mental illness in the perinatal period. So she was discharged from mental health care 2 months before her final pregnancy. So that might have been absolutely appropriate. This could have been a few years later. She was really well, really stable, no need to see mental health services. Off she went to get on with her life, that was grand. However, the issue that the inquiry was picking up from this case is that the discharge letter from mental health services back to her GP made no mention of considering any kind of risks if she were to get pregnant again. And even though when she did get pregnant with her 3rd baby, came to her booking appointment, the diagnosis of bipolar was flagged up and it was recorded, was identified, which was good. But at that stage, a plan was put in place that she could just sort of go to her GP if there was any problems with her mental health. So again, I suppose you can kind of see from not even what I said, I think it's probably reasonably obvious, but from what I've said already, this was a lady who was at really high risk of becoming unwell. And mums with bipolar and previous postpartum psychosis can get unwell within hours in the early postnatal period, so it can happen really quickly. And again, the kind of learning points. Okay, so a couple of key messages in that recent inquiry. This idea that I really like, but sometimes it's hard in practice, but genuinely we're all part of the solution. So anybody who has any contact with a mum, if that history is flagged up in any way, shape or form, that needs to be communicated to others. Again, I've kind of mentioned this already. It's a bit of a grim point, I think, after all the kind of work that everybody tries to do, but no statistically significant decrease in the overall maternal rate in the UK over the last decade or so. Lots of stuff was flagged up in the most recent inquiry about, I suppose, kind of differences and kind of inequalities. So mums who were Black, Asian, mixed ethnic, mixed ethnicity women at increased risk of dying. And this isn't mental health stuff, this is broadly speaking of dying in the perinatal period. Mums who were older, mums from more deprived areas. Cardiac stuff, as you saw from the little bar graph, is still kind of right up there with regards to the leading cause. Yeah, and again, I thought I was looking forward to talking to you guys, and it's all a little bit grim. But again, in one of the most recent cases, just that final point, there was actually a lot of cases seem to be coming through of actually really, really, really young mums. So kind of teenagers who ended their life through suicide, which is just grim. So I'm pretty much done. Just to kind of mention, I suppose, the new teams, because this is something that's going to be happening all across Northern Ireland. So I'm assuming you guys work in different trusts. So all the trusts got funding from the fabulous Robin Swan back in January 21. We're now in April 22. So unfortunately, the wheels of bureaucracy move very, very slowly, and I am a very impatient female. But the teams are now starting to get set up. So the kind of recruitment started, getting sorted out with accommodation, all those sorts of things, and they're at different sort of stages. So it'll be it's essentially a community mental health team, but just for perinatal, and there's one in each of the 5 trusts, all at different stages, even though we're meant to move in unison. That hasn't quite happened, strangely enough, across Northern Ireland. But Belfast is up and running, South Eastern Trust are pretty much up and running. Northern are kind of sitting in the middle, we're getting there. Western and Southern are a little bit behind. Not that it's competition, but be a 9 to 5 service, referrals mainly from GPs, midwives, mental health services of mums who are either currently unwell in the perinatal period or at high risk of becoming unwell. whole lovely mix, and our team together and the Northern Trust is coming together, and they're fabulous, and I really like everybody so far who's going to be in the team. That might change. But psychiatry, psychology, mental health nurses, social workers, midwife, OT, peer support, admin, all is kind of part of the team. And as I say, mainly it'll be for mums who have a diagnosis of schizophrenia, bipolar, previous postpartum psychosis, or severe depression. And then the kind of fun pre-conceptual counselling around medications, which actually I'm a bit concerned about, because there's no really easy right or wrong answers in those. It's all a bit of complicated balance and risk kind of thing. And then whole palliative resources if you want them. And that is me.
Thank you. No, I think you need to sit there. Yes, there are 3 seats for you. So we're going to open the questions until lunchtime. So we've got a bit more than 10 minutes. Are there any questions on the floor before I ask you a couple of questions myself from the group? Yes.
Thank you. Jonathan, I have a question for you. I'm Grace Maclennan. I do the antenatal anaesthetic clinic in the Ulster Hospital, and I've had a number of patients over the last while who've been referred who have a diagnosis of spina bifida occulta from childhood, but nothing to see, nothing written anywhere, no scans anywhere, and sort of left at 32, 34 weeks pregnant, sort of scrambling around to try and get an MRI to find out whether they do or don't have a tethered cord. Is there any better way just to answer that question or anything like that?
Is it on? Fortunately, probably not. It's very hard to tell what's lying under the skin without actually doing some neuraxial sort of imaging of it. That can be very little to tell from the surface what's there. I'd say if you do see a tuft or a dimple or something that's going in, I would image them. And again, that sort of picture there, I only sort of briefly covered onto it about a low tethered cord. It could look very normal from the outside, but again, there's other things like diastematic myelia and split cord malformations, and it's surprising that there are probably a lot of people with spina bifida occulta that have had needles put into their back and absolutely nothing goes wrong with them, and you could do it 1,000 times. But the question is that what risk do you accept, and for that one time that you may cause a problem. But I have also seen many things like an entire pedicle screw go through somebody's spinal cord and the person have absolutely no signs from it. So it's one of those things. It's probably an abundance of caution, but it's very difficult to know what's actually underlying that without actually doing some imaging.
Thank you very much. Any other questions from the floor? Yes, Sinead.
Thanks very much to everybody. I think the talks in that session were all excellent. So my first question is for Claire. With regards to asthmatics in pregnancy, so you're saying a third get better, a third stay the same, and a third get worse. Does that trend tend to follow, or do you find they would go off at particular times of pregnancy? Because I view it as like the physiological phase, and then they get more functional as time goes on. Do you tend to find there's a particular time that they would go off?
6 months is the peak time of increased symptoms generally. Now, the books when we read them say that what happens in your last pregnancy generally happens in your next pregnancy. That's not my experience. Definitely is different throughout pregnancies, and we've quite a few people who are on their second or third pregnancy and are experiencing different ways. But generally, the peak time for, I suppose, the peak amount of symptoms is 6 months for worsening of asthma.
And then my next question is for Johnny. So how much CSF do you take off at a shunt tap? You talked about a blue or an orange needle if you were doing a shunt tap on the wall.
If it was an emergency, you could easily take 40 mils without causing any problem. The other thing you can do is, again, by this stage, you probably will be chatting to somebody on the phone. If you stick a needle in, you can always connect a manometer onto it and see that you're bringing something down to normal pressure. That essentially, if it's high pressure, it'll fly out the top of the manometer, and if you're just bringing it back to normal pressure, that would be fine. But quite often, for some patients, we would do high volume lumbar punctures take 40 mils without any issue. But again, in that circumstance, the patient has far too much CSF in their head, so it's basically, it's hard to say. But 40 mils would be a good start.
That's that. And then the other question is, and we've talked about this in the past, do you think we have more scope for on the carries? Because we GA a lot of our carries, just depending on the advice that we're given.
I know, and it is very variable, and part of the problem is somebody could be told tell you they have a Chiari malformation when it's not really a true Chiari malformation. There are some that you would see that, especially if the tonsils are very low, you would be worried about them, or especially more so if they had a big syrinx in their cord. Like that paper said, I'm not sure just how good that paper was, but again, they found very few problems with it. And again, what they were saying was a fifth of the patients that they had, they only discovered they had a Chiari afterwards. And they had sort of gone through neuraxial techniques. What I would say is, in certain patients, an epidural may be okay, but if you're worried that you'll get an inadvertent dural puncture, you are likely going to make some of their symptomatology worse. Whether that is just temporary or permanent, it probably will be temporary. But what I would say is, I think whenever we chatted about this, is history always repeats itself, that if they've had 3 or 4 normal deliveries, it's fine probably just to do the same thing again. Where if it's the first one, you probably do have to be a bit more cautious and chat more about things.
Thank you very much. While the floor, just thinking of the next question, I've got one, maybe 2 for Julie that has come up. You probably can answer probably the 2 together. The first one is, anything can we do as an anesthetist to minimize traumatic experience? But the second one maybe includes that a bit further. Is there any correlation between traumatic delivery at birth and development of perinatal mental health issues?
So is there anything you can do to reduce traumatic deliveries? Do your job better? I don't know.
From your experience, if
Going back to personal experience, which is not what you're asking me, make sure the epidural actually works before you start doing the episiotomy. That's really helpful. I'm not sure, to be honest, what else to kind of say about that. The second point, there definitely absolutely is a... well, I suppose actually the first point, it's that, I suppose, finding out maybe a little bit about the history as such. And I suppose I'm not sure how much that's specifically you guys or the whole sort of team at that point, but kind of actually knowing a mum's history. So if she's had a previous traumatic birth, at least being aware of that, find out what happened with that, those sorts of things. If the mum has a history of any kind of abuse, any kind of sexual abuse, again, it's kind of helpful if people are at least aware of that. Don't need to know the details, but at least aware of that, and that can be just sort of helpful, at least. Is there a link? The second question: is there a link between traumatic birth and increased risk of perinatal mental illness? Yeah. And I suppose services in I'll not give you any figures or anything as specific as that, but yes, no, there definitely is. And I suppose the thing about actually traumatic births is it's a bit of a strange thing, because people are strange. It's not always necessarily that medically as such it's a traumatic birth. So, it could well be actually the mum perceives it as being traumatic. So to you guys, or the midwife or whoever else, it's all textbook straightforward. But for the mum, maybe actually she experiences it as being really traumatic because she feels not in control, or things aren't explained properly, or just her personality, all sorts of things. So it's not just, is it or has it been traumatic medically as such. In England, the perinatal services have been up and running for 10, 15 years sort of thing. And they have had massive investment of funding in the last 5 years or so. And they have really expanded their services, as I said already, sort of up to 2 years postnatal, but specifically around trauma. The huge investment has been mostly around psychology investment and increasing psychological input. And it's almost kind of like a separate bit of the team as such, but who focus more on sort of tocophobia, so sort of kind of fear of childbirth and previous traumatic births and sort of PTSD stuff and that sort of thing, rather than, I suppose, kind of where we're starting at the minute here in Northern Ireland is a bit more, because it's a smaller team and it's a new service, it's a bit more of a smaller focus on specifically mums who have bipolar and schizophrenia and things like that. But it'll be definitely something that we kind of need to be getting, I suppose, midwives generally upskilled as well. And certainly Shona Hamilton in Northern Trust, who is fabulous human. She kind of would do a lot around kind of work with mums who've maybe had previous sort of trauma and things. So yeah.
Excellent. I think we have time for one more question, if there's any on the floor. Otherwise, I've got one. So that's for Claire. Claire, actually two, but I will choose one. In a district general hospital, which patient should be referred to you as a tertiary center for asthma, for example, or which one would you like us to be worried about?
Okay, so obviously anybody who is on any of the biologics we should already know about, because we're the only prescribers of biologics in Northern Ireland, so I would hope no one else is on biologics that I don't know about. Patients who are on maintenance steroids or experiencing maybe 2 to 3 exacerbations a year prior to pregnancy, they would be people we probably should know about, because it suggests that disease was really not controlled before. I didn't touch upon it in the presentation, but the main reason that people are uncontrolled with asthma is because they do not take their treatment. Adherence is a massive issue. And studies still bear this out, and I look very carefully at patients who are referred in to us from all around the country, and still at least 50% of patients are not taking their basic inhaled steroid as prescribed. So that's always the first thing to check. We spend huge amounts of time on the phone to GPs asking how many scripts they've collected, and some people have had 1 or 2 inhalers in a 12-month period, but tell you, no, I take it every day without fail, no problem here. But that's the first thing you should always think about. If they're asthma poorly controlled, the likelihood is that they're not taking their inhaled ICS LABA combination as prescribed. But if you're worried about them, if they're frequently exacerbating, if they're eosinophilic, so if their eosinophils are above kind of 0.4, 0.5 in their blood, that suggests it's a major risk factor for exacerbation. We should probably know about those people. The tertiary centre doesn't necessarily need to know about all of them. Like if they're not known to anybody, their secondary care physician in their locality could see them, and they'll often touch base with us anyway. I mean, a quick email, I can suggest this person's probably okay to be sorted out wherever they are, or I think I need to see this person. Does that answer your question?
It does answer. Thank you very much. Unless there are a last minute question before lunch, I think I'm going to give the microphone to Damien if you want to tell us what we do next.
Next we're going to eat. That's the most important thing, is we're going to eat and caffeinate, because I think that's really, really important. I was once told before, I'm wearing brown shoes, so I'm true to type. I gave a talk at a meeting, it was a lovely multi-professional meeting, and they said, you must be the anaesthetist. And they said, yeah. I said, I am. How do you know that? And they said, because you've brown shoes, anaesthetists never want to show the spilled coffee. And so we need to go and get our lunch now. We have 1 hour for lunch, and we're back here again for 2 p.m. I'd like to say a really, really massive thank you to our 4 speakers, one virtually. I've texted the 4th speaker, but that was absolutely fascinating session. And I hope you didn't find it too threatening speaking to anaesthetists. Most people find us a friendly bunch. And I think it gave us fascinating insights into the other aspects of the care for these women that we need to be aware of. So maybe a final round of applause for our panelists. And lunch.